is sorry, doing the lecture will be Zoom from his place in Brazil, and we have right now Professor Gianluca in flash here with us. Thank you. We are very grateful today. Uh, we will try to make it on time. So before we open the lecture. Now we have two opening speech. One is from Dr. Muhammad Kurniawan, our head of department neurology, medical university, department neurology, medical university. Universitas Indonesia and Chief Dr. Cipto Mangunkusumo General Hospital to Dr. Muhammad Kurniawan. Please come to stage and give your speech.
Thank you, Dr. Henry. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. First of all, I would like to express my gratitude to Professor Gianluca Copolla and also Professor Mario Perez for his valuable time and also the lectures that will be delivered to us. I think we also have to give the appreciation to the headache division led by Dr. Tiara and also Dr. Henry because both of them and also Dr. Irma are very keen to increase our knowledge and also increase our institution to become one of the headache center in Indonesia. And on behalf of department, once again, I hope this meeting not stop until this time, but we can collaborate in the future, maybe in the form of doing joint research, and also maybe we can send our fellows or our staff to the Sapienza University, so we can learn a lot from you and also from your colleagues. I think that's all from me. Thank you very much once again, and I hope this will be a very fruitful guest lecture. Thank you.
Thank you, Dr. Muhammad Kurniawan. Yeah. Okay. Maybe another from opening speech from Dr. Tiara. It's okay. Okay. So I think with Professor Mario Perez already joined us. Not yet, yeah. Okay. So I think for the early morning, is it okay, Professor Gianluca, for having uh, your presentation until we waiting Professor Mario Perez come join us with online. Thank you. The place is yours.
Hello, everyone. Students and PhD students, medical students, residents. So let's start to say thank you for having me here. Sorry for my voice. It's not air conditioner for me. I took corticosteroids, but it seems to help me. But that's okay. And you know, I grew up with the electrophysiology and neuroimaging in my country. When I was a student during my medical course, already starting from the third year of my medical course, I did a lot of invoked potential EEG and so on. So I grew up with electrophysiology. And so I will show you many of these kind of studies, and I will try to teach you something about the pathophysiology of one of the most, you know, highly prevalent disorder of the brain, migraine. It's highly common in women, especially in women, with a ratio 3 on 1 female male, and it's highly under-recognized and under-diagnosed still now in 2025. So let's start with the question. This is my disclosure. There are many actors at the base of the pathophysiology of migraine, but everything is starting from the genetics. There are some genetic basic of migraine that we still don't know. We have several studies using genome-wide association analysis, but they are not well-based on some clinical, well-founded activity. And it's still, we are still in the process to understand the genetics of migraine. Probably it's polygenetic, so it's not based on one single gene. So based on genetics, we have many actors, many pieces of the puzzle that may take place in this process of migraine recurrence. Let's start with the first one, the most important one in many ways, that is the trigeminal system. According to the definition of IASP, the International Association for the Study of Pain, pain is, this is the definition, is an unpleasant sensory and emotional experience associated with ongoing of potential or potential tissue damage. Tissue damage. I will show you what is the tissue damage in migraine. And it can be composed of two components. The first one is the nociception, the perception of pain. When you feel pain, the feeling of pain touching something potentially dangerous, and the transduction of the painful information from the periphery to the central nervous system. And another part that is the more subjective one, the personal experience of pain, what you feel about pain. Why? Because for someone, pain is pain, for another is pleasure for someone, So it depends. Depends on the physical and psychological state, sometimes psychiatric state. So for the YASP, the tissue damage is what you can see there. So an inflammation, direct injury caused by a mechanical, a thermal, or chemical stress. They are all able to activate the nociceptors from the periphery. So the information is going up to the thalamus and then to the cortex. So you can, start something to avoid the pain, And this is some examples. But why the trigeminal system? Because there are many evidence that this is the system at the base of the perception of pain in migraine, headache. When the headache starts from the periphery, the feeling of pain. So it's called a conditio sine qua non in Latin, to feel, to perceive pain in migraine, headache. Why? Because there are some evidence from the past, from the beginning of the 19th century, that if you perform a neurosurgery and put some chemical substances or even touch the meninges, you can feel pain, referred pain over the forehead, of the neck, of the occiput. So regions where you usually feel migraine. So probably there is something within the meninges. At that time, there was something. So probably the tissue damage is at that level, at the level of the meninges, where the trigeminal vascular terminals are going to the meningeal arteries, the small meningeal arteries. So at that level, we have the release of some substances, pro-inflammatory substances, what we call the pro-inflammatory, neurogenic inflammation in English. And there are many of that, like potassium, substance P, bradykinin, histamine, prostaglandin, serotonin, nitrous oxide, proton donors, and so on. But among the others, probably the most important one is the CGRP, calcitonin gene-related peptide. That is a pro-inflammatory neuropeptide able to change vessels and neural activity at the same time. Nowadays, we have only also FACP, another target of even of migraine treatment. We have monoclonal antibodies against FACP, but we have in the market monoclonal antibodies against CGRP receptor and ligand. So at the level of the meninges, the dura, we have such as C fiber, the trigeminovascular terminals, and the release of CGRP. So the the granulation of the mast cells with the release of all the pro-inflammatory substances. And when this chemical activity is starting, you can feel, you can perceive the throbbing pain. Why? Because the fibers are sensitized. This is called the peripheral sensitization. So you can perceive the rhythmic fluctuation of the intracranial pressure, the pulsation. That is the pulsation of the arteries, actually. And this is probably why when you feel migraine, when you got an headache, a migraine headache, you can, even perceive pulsation when you're bending over, when you are moving, when you wake up, when you perform a physical activity, because you are feeling the arteries, the pulsation of the arteries. But the nociceptive information from the periphery, from the meningeal arteries, are going up to the thalamus, and this is the second order trigeminal neurons, and then up to the cortex, the third order trigeminal neurons. So you have such a convergence between the periphery to the center. But the trigeminal nucleus is composed by 3 nuclei. The cervical part, the middle part, but also part of the nuclei is going down to the neck, down to the C3. So you have this is the only brain nuclei going down to your neck. And this is probably why many of our patients, migraine patients, feel pain over the neck, starting from the neck and going up to the forehead, or vice versa, from the forehead to the neck. This complex neuroanatomical and functional system is called the trigeminal-cervical complex. But it's probably much complicated than this, because it's probably trigemino-cervico-brachial complex. And to show you a practical example of this complex, I will show you also. Maybe not. Maybe yes. Maybe the battery. Maybe. Oh. What I call the matrix system. Have you watched the film Matrix? So Wachowski? Someone of you maybe knows the Matrix film. Why Matrix? Because Keanu Reeves on the big building is awaiting a bullet from the other building. And what he did, he closed the eyes, first division of the trigeminal nerve, first division, trigeminal-vascular system. Then he put his head like this, spinal muscles, great occipital nerve, the other component of the trigeminal-cervical complex, and then he put the arms like this, trigeminal-cervico-brachial system. And this is the most simple and ancient system to avoid something that is potentially offensive coming from the forehead in front of you, boom, like this. And this is because of an external stimulus, external component, the bullet in this case, but also from an internal sensation of feeling stress, for instance. So this is a system that in the past was able to sense and avoid something painful, potentially threatening coming from this side. Nowadays, it's something that is involved in the perception and the avoiding of something that potentially is harmful for yourself, even from the inside, stress, for instance. And when the perception of pain from the periphery is going up and up, as is continuously running out, you have the ignition of the so-called central sensitization. And this is the definition. Abnormal neural excitability, meaning decrease in nociceptive threshold, increased reactivity to any kind of stimuli, painful or not. So even touching could be perceived as a potentially painful, and the enlargement, the expansion of the receptive field within the CNS to nociceptive stimuli. And from a clinical point of view, is seen as allodynia, cutaneous allodynia, and from an electrophysiological point of view, as an increase in cortical excitability. Allodynia. We study the central sensitization in migraine. You see the somatosensory evoked potentials. Probably you have you know what I mean for somatosensory evoked potential, and it's a peripheral stimulation of the the wrist, electric stimulation, repetitive stimulation, and you see the movement of the thumb, and you can acquire the activity of the parietal cortex from the contralateral side, and you have the so-called N20 peak, and you can measure the amplitude of the signal. So by collecting information from healthy control, this is the healthy control, this is the amplitude, migraine without aura between migraine attacks when you have no pain, you have the reduced cortical activation at the time. So hypoactivity, not increase in cortical excitability, but you have a huge increase in cortical excitability where you have a migraine attack in episodic migraine in gray, and a migraine attack during the never-ending migraine attack of chronic migraine, in this case, in red. This is a clear evidence of increasing cortical excitability, evidence of central sensitization in migraine during attacks of episodic or chronic migraine, but not between attacks when you have no migraine. But this is at the level of cortical reactivity, but you have the same when you acquire the blink reflex. So a way to study, an indirect way to study the function activity within the trigeminal nucleus. During attacks of migraine, increase in central trigeminal activity as compared to pain-free phase. You clearly see this increasing excitability. The same use laser evoked potential. So pain-related evoked potentials. This is to study the C fibers from the periphery to the center. And this is acquired from the vertex. The same as looking for the threshold of the corneal reflex. That is, a way to study the trigeminal activity, especially looking at the C fibers, not a delta, but a C fiber, the more painful one. And, another proof that is from the periphery that is starting the pain in migraine is, to prescribe monoclonal antibodies against CGRP, the molecule, the neuropeptide that starts, it's at the base of the beginning of a migraine attack. So if you, prescribe monoclonal antibodies, in this case against the receptor, you have not this drug in your country, it's called erenumab. This is the only monoclonal antibodies against the receptor. We have 4 monoclonal antibodies, erenumab against the receptors, and 3 against the ligand, fremanezumab, galcanezumab, and eflinezumab, the only, by infusion. In this case, is against the receptor, erenumab. We prescribed erenumab 3 times, and we acquired blink reflex of erenumab, blink reflex and somatosensory evoked potentials in the same patients 3 times before every monthly injection of erenumab. And what we see was a clear decrease in the number of headaches with the number of days with migraine clearly decreasing, significantly decreasing, but also decreasing in the area under the curve of the blink reflex already after the first month, immediately. And only after 2 months, we see something changing even at the cortical level. So we know that monoclonal antibodies against CGRP are not passing in such a great quantity the blood-brain barrier. It's very small quantities. So what we see at the cortical level using evoked potentials is just because of a modulatory process from the periphery to the center. So we see we have seen the first effect, immediate effect, already after 1 month, but it takes 2 months to have an effect at the cortical level, neuromodulation. We did the same, again, the button. We did the same using Botox, botulinum toxin type A. That is, I don't know if you have this treatment in your country, probably yes. In chronic migraine. And we studied with the same procedures, some patients, again, 3 times. And what we found, again, a reduction in headache days, clearly reduction in headache days, so the efficacy of the drug. But we have seen the efficacy, electrophysiological changing, only at the trigeminal nerve, nothing at the cortical non-painful level. Why? Because no effects at the somatic evoked potential, such an effect using pain-related evoked potential to statistical significant reduction, increase in the blink reflex. Why? Because Botox is actually acting from the animal model we know at the C fiber level. Monoclonal antibodies, they act at the A delta fibers level. So completely different mechanism and fiber to be involved. But who actually ignites migraine? At what level? Who starts the beginning of an attack? CGRP, yes, but who say, please release CGRP? We still don't know. We have many hypotheses. The 2 main hypotheses are that probably is due to a cortical spreading depression. What is this kind of long name, cortical spreading depression? It's a wave of initial increase in cortical excitability, followed by a prolonged spreading decrease in cortical excitability. Think about the hola at the stadium. Ooh, like this, spreading across the cortex. And there are some evidence on the animal model that this wave of electrical activity could start the activation of the trigeminovascular system. But from someone else, the start is within the brainstem, maybe trigeminospinal nucleus, but also some other area, monoaminergic area within the brainstem. That probably is the best way to explain why. Because cortical spreading depression is at the base of migraine aura. And so focal neurological symptoms, visual symptoms, paresthesia, language disturbances, but it's not at the base of migraine without aura. So the majority of our patients. So probably the start is within the brainstem. And this brings us to the other piece of the puzzle, the brainstem. And we say that all starting from the brainstem. Why? Because of this spot within the brainstem. This one, you see? It's the dorsolateral part of the pons. And this study, seminal study, very old study, you see, 1995 to 2001, performed with the PET scan and with the function MRI. They see this spot. Every time I show this spot to my neuroradiologist, said, this is an artifact. This is an artifact. But based on these 2 studies, we say that this is probably a migraine generator. But despite this evidence, when we look at the article, when we read the article, we see that there are many other areas being activated during a migraine attack. So not only the dorsolateral part of the pons, this one, but also a part of the orbitofrontal cortex, part of the cingulum, the inferior singular cortex, the left temporal, the right temporal cortex, so bilateral, the parieto-occipital junction, bilateral. So there are many areas involved in the beginning of migraine attack, central nervous system areas, but especially the brainstem. And this is another example. And nowadays, by looking into the brain using more modern techniques like this one, that is a box-based morphometry. I don't know how much you are used to MRI, modern techniques of MRI. This is a way to study the volume of each area within the brain, so the density of the neurons, and it's more prone to study learning activity within the brain. Someone have seen some decrease in the density of neuron within some brainstem area, not only the dorsolateral parts of the pons, the so-called migraine generator, but also the periaqueductal gray matter, the dorsal medulla, the raphe nuclei, and the spinal trigeminal nucleus. So probably the brainstem is clearly involved in migraine attacks, and this is especially between migraine attacks when you are predisposed to the recurrence of an attack. But not only the microstructure, but also the microstructural of the brainstem is abnormal in migraine. This is DTI, diffusion tensor imaging. You can perform this kind of analysis to obtain some metrics, fractional isotropy, mean diffusivity, axial and radial diffusivity. They are all the the spreading of the proton molecule within the brain that you can study. This is a way to study ischemic penumbra after a stroke. You can also apply this technique to study migraine. And if you follow the migraine cycle, I mean, between migraine attacks, going to the tipping point when a migraine attack is starting, the premonitory phase, then the ictal phase, as you can see here, from the interictal phase going up to the preictal and ictal phase, you follow the migraine cycle. And what they have seen is huge changes within the PAG, the PAG, the dorsolateral pons and dorsomedial pons, as well as the spinal trigeminal nucleus and some thalamic and midbrain nuclei. So there is some changes in the microstructure within the brain, the brainstem, according to the migraine cycle. So neuroanatomy that follows the cycle of migraine, interictal, preictal, and ictal, and even postictal phase. Brain plasticity. The same from a functional point of view, and this is fMRI, resting state and functional fMRI in response to a painful stimuli. In this case, is over this region. So maybe the third branch of the trigeminal nerve. So if you follow the migraine cycle, you clearly see some changes according to the distance from the last migraine attack and up to the close to the attack, premonitory phase, then the attack is like a reset system. So again, some changes, functional changes in this case, within the brainstem, especially the PAG and dorsolateral parts of the pons. Again, the so-called migraine generator. And this is during an attack of migraine. And again, some changes during the premonitory phase of migraine. But we have seen microstructure, microstructure, functional activity. Now is the time for metabolic activity. This is PET scan. PET scan for monoamides, especially 5-HT 1B receptors. And what the Danish group have seen is that the metabolic activity within the midbrain and the brainstem is changing again according to the distance from the last migraine attack. Again, brain plasticity, not only from a micro, micro, and functional point of view, even from a metabolic point of view, our brain is plastic, is changing, even in the structure, every day, every moment of our life, even in the case of the migraine cycle. But why the brainstem? Why the brainstem is so important in migraine, in understanding of migraine pathophysiology? Because of its functional activity. It sets the signal to noise of what you perceive from the periphery going up to the center. It elaborates the information and, pass the information to the thalamus, but sometimes direct to the cortex because you don't need to pass through the thalamus when you are feeling something painful, going up immediately because you have to avoid pain immediately, like a fire, and going away out. But in many times you pass the information to the thalamus, and then from the thalamus to the cortex through the thalamocortical loop. So it set the arousal, to process the arousal system, to set the sleep-wake cycle, is to, to perceive sensory stimuli, elaborate sensory stimuli, but also to induce antinociception, for instance. So there are many, functional meaning of the brainstem that are clearly involved in migraine recurrence. But also, brainstem is important to set the central sensitization process. Why? In this case, because if you have an algometer, so a pressing pain system, if you press some muscles up to obtain pain, you can acquire fMRI, and you see an increase in bold activity within the brainstem, in parallel to perceive pain. And this is a clear evidence of brainstem involvement in the central sensitization process. But the brainstem is also important, as I told you, in antinociception. Why? Because you have an old system. The system was called at the very beginning DNICs, diffuse noxus inhibitory controls. That is part of the brain, composed of part of the brains like the monoaminergic nuclei, especially serotonergic raphe nuclei, but also noradrenergic locus ceruleus and the PAG, periaqueductal gray area, that is ophthalmic. And when you have a strong tonic pain, like when you put your hand in water at less than 3 degrees, is very painful, or more than 48 degrees, that is painful as well. You can ignite, start the activation of this brainstem system, the NICs, now called heterotopic pain stimulation. And you can start the brainstem antinociceptive process. That is not a cognitive process, not at all. The cognitive process is starting from the frontal cortex and is late in time, usually. With this mechanism, experimental mechanism, you can even suppress cortical activation like the evoked potentials. We did it study using visual evoked potentials, repetitive checkboard simulation. We acquired the visual area activity from OZ, and this is what we call habituation, the reducing this response with the repetitive representation of the same stimulus. Habituation in LP controls, this is LP controls, baseline, no pain, pain, lack of habituation, reducing the first response and increasing the response along the stimulus. This is what we call lack of habituation, then after effect. This is during pain, tonic pain. So activation of the NICs, heterotopic pain mechanism. But what happened in migraine? Yes, an effect. No effect in migraine. Lack of synaptic plasticity. It's impossible to learn from a migraine's brain, impossible to learn to be modulated by the brainstem. So something that is not working properly within the brainstem, especially monoaminergic nuclei, APAG. The same when we use the laser evoked potential, an effect in LP controls, an effect, statistically significant using immersing our hand within a water at -3 degrees is very painful. I learned a lot of strong words, I must say, in this way. But no effects in migraine, nothing. Lack of an effect because of some malfunctioning system within the brain stem antinociceptive system. But we know from cognitive evoked potential, this is CMV, cognitive contingent negative variation. That is an event-related potential, cognitive one, very late in time, 300 milliseconds. And we know from this study that if you measure the level of serotonin in the blood, platelets, it follows the cortical response. So they are strongly related with serotonin, monoaminergic activity and cortical activity. The same by recording brainstem auditory evoked potentials. Again, in migraine according to the serotonergic activity. And the same for, this other response that is intensity curve with a click at different intensities, and you plot this kind of curve that is inversely related with the central availability of serotonin. And it is steeper in migraine, you can see here, as opposed to the dashed line of healthy controls. This is another evidence of reduced serotonergic availability within the brain of a migrainous. But there are many other evidence that even other monoamines are involved in migraine pathophysiology, like dopamines. Look at the symptomology accompanying the headache phase of migraine. Nausea, vomiting are all symptoms related to dopamine. But also acetylcholine was involved in migraine pathophysiology, like giving acetylcholinergic activity drug to be a preventive of migraine in many ways. But the brainstem is also involved, we know, in setting the neurovascular coupling. Monoamines setting the caliber of the vessel at the cortical level is controlling them. So it probably the brainstem also at the base of the recurrence of cortical spreading depression. So this wave, this hola within the brain that is at the base of focal neurological symptoms in migraine preceding or accompanying the first phase of a migraine attack, migraine aura. So the ignition of CSD. So let's move to the cortical involvement in migraine, cerebral cortex, and the most clear and evidence of cortical involvement in migraine is the CSD, cortical spreading depression. And this is Professor Aristides Liao from Brazil, who studied this kind of electrical or neurovascular phenomenon that is called cortical spreading depression. This is the study, published study, is freely available online. It's very interesting studies, I must say, to read. And we know from this study, from the animal model, this is rats, this wave you see of increase in excitability, followed by prolonged decrease, even a suppression of cortical activity. You see spreading across the cortex, and then returning to normal. Spreading. You see the spreading activity, spreading. We know from the animal model that is spreading at 3 millimeters per second per minute. 3 millimeters. We measure the velocity of spreading activity, and you can induce cortical spreading depression just putting one finger over the meninges like this. Tap, spreading depression. Tap, spreading depression. Mechanical activity. But we have seen the same wave even at the cortical level using the fMRI in migraine. Just one study up to now. One single study. This is the study of Nusina Gicani from US, showing this. I'll show again. You see this wave spinning from the occipital pole of increasing cortical excitability followed by prolonged decrease in cortical excitability. So it's called cortical speeding depression, but at the very beginning it's an increase in cortical excitability. And we must say that it's a neurovascular phenomenon because there is also an accompanying increase in regional cortical cerebral blood flow, followed by a decrease in cortical cerebral blood flow. So it's a neurovascular coupling because of the brainstem. Again, neurovascular. But for someone, cortical speeding depression could be involved also in migraine without aura. Why? Because there are some, small, little single cases showing some changes using the TAC scan, CT scan. And in just one patient, 2 patients, some changes within the brain, transient changes within the brain of patients, single patients of migraine without aura. But the most compelling evidence that this is not the case, cortical speeding depression, silent cortical speeding depression, is not at the base of migraine without aura attacks, is the fact that if you give a drug, in this case tonabersat, that is an inhibitor of cortical speeding depression, never went to the market, never. It was a pharmaceutical company from Switzerland. It was never put in the market. You can suppress migraine aura, but not migraine pain. Not migraine pain, just migraine aura. So this is to say that probably there are 2 different pathways, one for aura, one for pain, at different threshold levels. So you can have in the same patients attacks of migraine with and without aura. This is common. Very common in our field. It's rare to have one single patient with all the same migraine with aura attacks. But it's always, the majority of cases, a combination of migraine with without aura, because it depends on the threshold. Okay? But another way to study and to check for the involvement of the cortical activity in the recurrence of migraine is by recording again evoked potentials. So to evoke a cortical activity by feeding the brain with a sensory stimuli, controlled sensory stimuli. In this case, using a visual stimuli checkboard and by recording visual evoked potential. We did so, and what we found was this wave, this graph of increase in cortical excitability, what we called cortical hyperresponsivity. Why hyperresponsivity instead of cortically hyperexcitability? Because at the very beginning, it was not really high, the excitability, it was lower. Lower than healthy controls in gray, lower than migraine during an attack, increase in cortical excitability because of central sensitization during an attack in gray. In green, you can see this is during an attack. This is between attacks, red, between attacks, reducing cortical excitability, but increasing over time during the repetition of the stereotype visual stimuli. And this was called by us cortical disexcitability or cortical hyperresponsivity instead of cortical hyperexcitability. When we have a clear evidence of cortical hyperexcitability during an attack of migraine in green. You see, at the very beginning, you have this increase in cortical excitability as compared to healthy control in gray and migrainous between attacks. And you have a cortical response normalization across the blocks, across the repetition of the same stimuli during an attack. You see, the initial increase in cortical excitability, central sensitization, is transient. It's not persistent because you see this reduction across the block. Normalization of what we have called cortical hyperresponsivity during an attack of migraine. But this is visual evoked potential, but we obtain the same pattern by recording somatosensory non-painful stimulation. Again, in red, between migraine attacks, lack of habituation, sensitization during attack, transient, then followed by habituation, and this is the healthy control. The same using auditory stimuli, increase hyperresponsivity, healthy control, but the same by recording cognitive evocative potential, lack of habituation in migraine, as opposed to normal habituation in healthy controls. The same by recording blink reflex, trigeminal activity, lack of habituation, sensitization, normalization during attack, lack of habituation using pain-related evocative potential, laser stimuli. But do you think this is a static phenomenon? No, it's not static because it's again depending on the distance from the last migraine attack. Again, brain plasticity, synaptic plasticity. You see this clear evidence of an association between the distance, the days elapsed from the last migraine attack and somatosensory evocative potential amplitude, somatosensory evocative potential, lateral inhibition within the brain. Again, visual evocative potential, the degree of lateral inhibition within the visual cortex, visual photostress by using blanching light, VEP, EEG in the connection with some other areas, and even by performing TMS, transcranial magnetic stimulation, the threshold to evoke TMS, MAP, motor evocative potential, the short after inhibition, again, in relation to the distance from the last migraine attack, the CK, a way to study brain inhibition using TMS, and again, even by recording EEG event-related desynchronization and synchronization in patients with sleep deprivation. So this is a clear evidence that the factor time of recording, the point where we are in the migraine cycle, even between migraine attacks, is fundamental to set the level of cortical excitability in patients affected by migraine. Something classic. We studied this brain plasticity following the migraine cycle along 30 days, every day for 1 month, in choosing the patients by acquiring 3 attacks for each patient, so 6 attacks, in collaboration with the Taiwanese group of Xi Junwan, Professor Xi Junwan. And sorry, what we found by acquiring EEG every day for 30 days, and by recording the activity within the brainstem and the S1, the primary somatosensory area, was this increase in the brainstem and S1 excitability you see here, just the day before the beginning of a migraine attack, 24 hours before the beginning of an attack, in preparation of the attack. During the attack, we have seen a huge inhibition of the response. So increase in excitability within brainstem as S1 before 24 hours before the attack, followed by a prolonged inhibition during an attack. So these probably are the neural substrates involved in the attack generation, include the somatosensory system starting from the brainstem, so spanning subsequently to S1, the primary somatosensory area. But we know from some study that this phenomenon, the lack of habituation, this increasing cortical responsivity, is based on genetics, on its familiar character. Why? Because according to these studies performed in children, there at some age, across, between 20 to 29 years old, there are some changes within the brain according to these visual evocative potential studies. You see, no, sorry, this is cognitive evocative potential study. You see this huge difference starting from 20 years old in healthy controls, normal habituation, and migraines, lack of habituation. This is a lack of brain maturation in migraine. And again, when you try to correlate the cortical response, visual and auditory, in children and their parents, you find a huge correlation between the two. I belongs to my family, even from a cortical point of view, cortical activity point of view. And the same in migraine. They are related, inherited. And even in patients at risk means someone that is not affected by migraine, not yet, but at risk because of first-degree parents affected by migraine. I have my mother with migraine, my sister, my mother. So yeah, I will probably develop with time, with years, full-blind migraine attacks. So in this case, in this kind of patient defined at risk, they have the same brainstem, in this case, this is blink reflex, response, lack of blink reflex habituation using red and yellow in patients at risk, not yet affected by migraine, even more so than patients with full-blown migraine in green, sorry. And this is in blue, healthy controls. So you are in the potency of develop migraine attacks. So something inherited. But in trying to understand if at the base of this phenomenon, this cortical phenomenon of lack of habituation, there is some metabolic problem in migraine, in collaboration with the group of Belgian group of Professor Schonen and with Marco Lisicchi from Argentina, that at that time was a PhD, doing a PhD program in Belgium, we recorded in the same patients the functional activity using evoked potentials and the metabolic activity. The metabolic activity, again, the metabolic activity by acquiring PET scan in the same patients, PET and visual evoked potential. What we have seen is that in migraine is red, blue are healthy controls. In migraine, when you check for the ratio between the amplitude of the VAPs and the metabolic activity at the PET scan, you see that you have such a prevalence of the functional activity. The functional activity instead of metabolic activity, you have an increase in cortical hyperresponsivity instead of having a huge metabolic activity. While in healthy controls, you have more metabolic activity, but less functional cortical responsivity. You can clearly see this difference. Migraine here, healthy controls on the other side. What's the meaning? In migraine, you have an increase in cortical reactivity with low energy reserve, very low energy reserve. That is the opposite of healthy controls. Less cortical reactivity and more energy reserve. There are many spectroscopy studies showing that there is such a low battery within the brain of a migraine, low battery. I will give you an example. It's like a huge, very expensive Ferrari car. It's very expensive, huge car, very powerful, go up to more than 300 kilometers per, very, very, very speedy car, but with a low energy reserve.
5 minutes more, sorry.
5 minutes, just
Yeah.
5. Oh my God. So let's look at the other actors, the thalamus and the hypothalamus. The thalamus, because of this kind of studies. I was a resident for 1 year and a half in Belgium in the Professor Schoenengai lab. At that time, I studied this kind of high-frequency signal, you see. And this is embedded within the classic somatosensitive evoked potential, the N20. If you apply a digital filter between 450 and 750 hertz, you can, disclose this kind of activity that reflects the first part of the bar, the thalamocortical activity, the second one, the primary cortical activation. This is an easy way to study thalamocortical activity and cortical activity at the same time. And we did so in healthy controls, and this is healthy controls with a normal habituation. And we did the same in migraine between attacks when we have no pain. Episodic migraine, lack of habituation, but reduced thalamocortical activity. Reduced thalamocortical activity in the presence of a normal primary cortical activation. During attacks of episodic and chronic migraine, again, we have initial sensitization followed by a normal habituation, but restoration normal thalamic cortical activity in presence of an increase in primary cortical activation, sensitization. central sensitization in episodic and chronic attacks of migraine. In medication abuse headache, we have the initial increase in cortical excitability followed by prolonged continuous increase in cortical excitability. This is a persistent central sensitization with an increase in thalamocortical activity because of the involvement of the thalamus in the process of central sensitization. This is because of this theory we postulated in 2007 on cephalagia that probably migraine belongs to this kind of brain abnormal activity that is called thalamocortical dysrhythmia. That is a way to explain neurofunctional phenomena. It's at the base, for instance, of partial epilepsy and or absence, typical absence epilepsy. If you have a disconnection of the thalamus from the brainstem monoaminergic nuclei, this phenomenon can generate some abnormal activity within the thalamocortical loop. So you have less activation of the primary pyramidal cells and GABAergic inhibitory interneurons within the brain. So you have a lack of lateral inhibition. This is a way to some cortical phenomenon to take place, like what they call the age effect. But we have seen from some authors that even the volume within the thalamus, some thalamus nuclei are reduced in migraine between attacks. And this is the nuclei. This is voxel-based morphometry. But we did also DTI, diffuse tensor imaging, and FA, fractional isotropy, in migraine between attacks was hugely increased, significantly increased bilaterally, as opposed to normalization during attacks. Changed according to the attacks and according to the distance from the last migraine attack. Again, brain plasticity using DTI in migraine by looking especially at the thalamus. But at certain point, we moved from the thalamus to the hypothalamus. And this is because of these two studies. The first one, both using PET scan, and found that this activation within the hypothalamus just the day before the beginning of an attack. The day before. And the day before, we found that the functional MRI using ammonia of the nostril, this activation of the hypothalamus breakthrough 24 hours before a migraine attack. This is a continuous every day for 1 month recording of fMRI within one single patient. Activation of the hypothalamus during the attack. And the increase in the activation of the brainstem during an attack and hyperconnectivity between the hypothalamus and the brainstem during an attack of migraine.
1 minute.
We also studied, I'm approaching the end of my presentation. We also studied DTI of the hypothalamus, and we found a huge change between ictal and interictal phase. And we also seen that the metrics, the DTI metrics, the hypothalamus are related to the duration of an attack. So hypothalamus could be involved in the beginning and even setting the end of an attack. But is this specific to migraine? No, because the hypothalamic activity was seen even in cluster headache, hemicrania continua, hemicrania paroxystica, ZUNT, whatever you want. So this is completely aspecific, not related to migraine. And sorry. And probably this is not useful. It's not working. There are some evidence even the functional connectivity between the thalamus and the cortex is abnormal in migraine, especially during the attacks when you have a disconnection with the thalamus and this kind of cortical networks, especially related to some cognitive problems within the brain, like disturbances of the verbal and memory activity during attacks of migraine. So disconnection between the thalamocortical network activity. And there is huge evidence of disconnection of all the networks, cortical networks, studying fMRI at rest in migraine between migraine attacks and increasing connectivity within the DMN, default mode network, and some salience networks, sensorimotor networks during attacks of migraine. So, and especially in chronic migraine, where we have a huge involvement of many other networks within the brain, according to the severity of pain. Even DTI, the amount of involvement of white matter fiber bundles is especially characterizing the chronic migraine patients, not specific at all, because we have seen the same in fibromyalgia, rheumatoid arthritis, trigeminal neuralgia. So this is completely unspecific. And it's probably related to some predisposition, because there is evidence even in children affected by migraine for the same cortical abnormalities. So this is a predisposition to migraine. So this is my one of my last two slides. This is what I call the migraine constellation, to sum up all the the station of the brain that are involved in the process of recurrence of migraine, the cortex, brainstem, and so on. And this is my last slide. So to sum up, if we have a low energy reserve, an increase in cortical excitability, hyperresponsivity, and you have this genetic predisposition. If you have a migraine, you have a sort of threshold to develop an attack. But if you have migraine plus stress, if you have migraine plus comorbidity, like especially psychiatric comorbidity, but also vascular comorbidity, sleep disorders, and so on, you have such an increase in the probability to ignite a so-called stress response that is within the hypothalamus. So you activated the hypothalamus in turn activated the trigeminal-vascular system that is a way to sense pain, and then there is the ignition of a migraine attack. So attacks recur. The trigeminal-vascular system reset the brain, so you have a recovery from the attack. And this is just to highlight to you that probably it's time to move from the original definition of migraine as non-organic central pain, sine materia, we say, without evidence of the anatomical involvement. We should move to the definition of biobehavioral, organic, and maladaptive central pain, which incorporates in the same definition the biological and the behavioral aspect of the disorder, as well as the accompanying morphofunctional abnormalities, plastic abnormalities we have seen. Thank you.
Thank you very
Sorry
much
to
for your lecture, Professor. Wow, what a wonderful lecture. Very insightful. And now, sorry, and now we're coming to the next session. Thank you, Professor Mario Perez. He's now joining us from Brazil. Right now it's 23 midnight here, Prof Mario in Brazil. Thank you for your time, Professor. Now you will be going to make a presentation, a lecture about how to make a headache clinic from academic to practice. Professor Mario Perez is president of the International Headache Society. Please, the time and place is yours, Prof. Mario Perez. Do you hear me well, Professor?
Thank you. Yes, thank you. Thank you for letting me speak online. So I'm back here to Brazil. Sorry about my voice. It's a little funny, but we can go and start. So let me share the screen with you. And are you?
Yes, we already.
Are you getting the presentation good?
Yes.
Is it on full screen or just the?
Now in full screens, Professor.
Is this going back and forth?
Yes, going back and forth.
All right. So I like to cover many things, and I like to leave some minutes open for your ideas and local needs. We'll talk about several ways of setting up a headache clinic, but first we have to understand levels of care. Of course, primary care is what is supposed to take care of most of the chronic diseases. in general, 80% of the diseases in a mild level or on an or easy to manage level will be taking care of primary care, and then secondary care, neurology, and tertiary care, a subspecialty. But for headache care is actually more than that. We have to understand also before some healthcare provider is seeing the patient, we have to understand that there is self-care that is done at home, at work. There are cultural-based, community-based treatments. There is religious care. And then non-MD healthcare providers are very important, like the pharmacists. In Brazil, for instance, most patients are getting their treatment and their acute treatment in the pharmacy. They are not getting medical diagnosis or treatment, and very few candidates of migraine prevention are really getting migraine prevention. Less than 5% in Brazil of migraine patients that should be on prevention are really getting it. Those numbers are not really a lot better than that if you consider some studies, even in the United States, or even in with high developed countries, high income countries, the number is around 20 or 30% of patients that really get preventive treatment. So in order to understand who can also assist the patient, we start also with the community health workers. In general, it's attached to the family medicine structure. These people go in the community and can play a big role in terms of managing also diseases, detecting diseases and treating it. And of course, then you have a more trained therapist or a healthcare provider, a nurse, a physical therapist, a dentist, a psychologist. And then you go to a physician. And then we start the primary, secondary, and tertiary levels, right? So it is actually right before the primary care level that we start managing care. And what does it have to do with headaches or headache centers? Is because the referral pattern is very important. Where is the patient coming from? And in order to decide if the headache clinic will be private or in the public sector. So regarding non-MD healthcare providers and medical providers, you can get the treatment in the ambulatory setting or in the hospital. And even in the hospital, you can get ambulatory consults. Inside the hospital, you can get emergency and sometimes hospital admission. Also, you may need procedures and operating rooms and some settings where you can get easily in the hospital. So if we understand and consider secondary versus primary headaches and who should see, this is just a figure, an exercise of how the headaches can be managed in terms of all the levels of care, and considering this figure of comorbidity, also considering that 1/3 of migraines are pure in the population, meaning that they're not associated with any other condition or disease. Those pure migraines tend to be probably easier to take care of. So then we could make a strategy in terms of populational based care rather than individual care. So when you think of a headache center, you have to think of what kind of managed care you're doing. Are you managing a population, and or you're just managing individual people's, like persons that are looking for you, coming for you. So why that is so important? Because you may have to include in your setup some screening features. Sometimes you have to look for the patient that is undiagnosed or underdiagnosed, that is being seen or managed in other specialties, that is like trying to get relief from headaches by looking at things that are not going to help. Like it's common, people with migraine, because they have nausea, vomiting, they think their migraines are coming from the liver, and then they go to maybe a gastroenterologist to check that. So there is some waste of time in some conditions related to headaches. You see, usually people with migraine aura go first to ophthalmologists. Usually cluster headaches may go to ENT, thinking that they have sinus headaches. So it is something that we have to keep in mind. So why do we need a headache clinic, a headache center? First, because there are rare and complex cases with challenging diagnosis and treatment. There is a need for subspecialty in multidisciplinary care. There is a shortage of knowledge and training, and sometimes you need procedure or advanced therapies that only a specialized center is able to deliver. And the other question is, who is the headache specialist? In general, is a neurologist or a physician with additional expertise in headache medicine. Why neurologist? Because most of the conditions that are secondary are neurological conditions, because neurology is a clinical specialty compared to sometimes, some surgical specialties that are more, like ophthalmology or ENT. They're less clinical, they're more surgical. Also because most of the primary headaches are related to the brain and related to neurological aspects. So the headache specialist is most likely to be a neurologist. You can get here and there other people, other specialties or general practitioners, primary care physicians that are very, very welcome to become headache specialists too. There are several countries like the UK where primary care physicians can have some sort of training or and deliver a headache care even between their family practice or general medicine scope. And so a headache specialist may have a formal fellowship training or may have an extensive clinical experience, and there should be, or it is advised that there is some affiliation or even a certification by organizations. What should the headache specialist know? Of course, the criteria. Very important to understand neuroanatomy, pharmacology. There is a need to be trained in nerve blocks, in Botox, and also understand infusions. Differential diagnosis is very important. Understand comorbidities, have access to emergent therapies, and also be able to do a non-pharmacological plan, to understand behavioral therapies, to understand mental health, and to be able to help patients, and not all patients refer to psychologists or to psychiatrists. Pain is a subjective symptom, and a condition that needs a good mental health approach. So we have to be trained, and we have to give special care related to mental health. And also research skills are very important. Clinical trials, reading, papers, very important. If you write your experience, share your experience with the scientific world, go to meetings, talk to people. If you start your own center, your own practice, and don't get cross-pollination, like you don't learn anything else, you get stuck, and in 5 years you'll be already gone. So it's part of medicine. But in the headache world, we are seeing a lot of changes, and it's probably in the future years we are seeing more and more evolving changes in concepts and new discoveries. So if you start today, you're gonna have probably in the next years, you're gonna have to change a little your practice, because naturally new things will appear. So what should be the best structure? You have to think about the physical structure. You need a reception, a waiting area that is different from what a general waiting area, like it should be quiet, comfortable. Sometimes, some patients come with very heavy perfumes, and other patients get annoyed. So you may have to, understand that and make some policy about it. You need some consultation rooms. You need some procedure room. It is nice to have infusion therapies, and it's nice to have some access to neuroimaging. You don't have to have a CT scan or MRI right next to you, because rarely you're going to need, unless you are in the ER, we are seeing very, very acute patients. In general ambulatory care, I mean, you just send people to do imaging, or if it's too urgent, then you send them to the hospital. Very important to understand also, and to include telemedicine in the care of patients. Of course, you can select your patients according to where they live, and that depends on what kind of structure you have in terms of referral, or if the headache center is going to be public or private. If it's public, and if the health system requires a local referral system, then you're probably not going to need telemedicine. But in general, you may have people that are following up with you, but sometimes traveling, or sometimes cannot make. I know traffic in Jakarta is super good, and rarely you can see big traffic, right? So people don't. I'm seeing here in São Paulo is the same thing. Is the traffic is also heavy, and I have some patients that would like to come, but in the end they are kind of busy, and they don't want to spend 1 hour in traffic to come to the clinic, and another hour to come back to their home. So they spare 2 hours by doing the consultation with telemedicine, and this is very helpful. And I'm doing more and more telemedicine. even in patients that live like, 1 hour driving from me in Sao Paulo. What about equipments? For a basic consult, you don't need a lot more than the regular, blood pressure, pulse, weight scales. If you are doing infusion, of course, chairs and beds. It is nice to have some emergency trolley around. People get, people faint, people get, all sorts of things while you're examining them or even in the waiting room. But also, it is nice to think about some advanced equipments, like if you're doing nerve blocks guided with ultrasound. I personally, I don't do it because, I think it would be nice to do, but I think anatomically guided blocks are also effective. But if you have ultrasound, uh, you can do some more difficult blocks, or you can do hydrodissection. You can actually target with more precision the procedure. In terms of softwares of patient tracking, Irma presented the headache diary that you developed. I think for some patients is important. There are 2 types of diaries, in my perspective. The diagnostic diary, when you're starting to follow the patient and you want them to, understand their features, their duration, frequency, and even, occurrences of the headache. And then there is the follow-up diary. It is nice to have information, but is also sometimes tiring for the patients, because if they are getting daily headaches, they get everyday negative feedback on filling out the diaries. But you, of course, is up to the physician what kind of directives you do. You ask patients to feel like sometimes I like to check and get information about their sleep, so they fill out sleep diary together with a headache diary. Another good equipment, I think it's very nice to have, is the non-mydriatric retinography. You can see the retina very well without dilating the pupils, so you can screen papilledema, you can avoid neuroimaging in many cases, and you can sometimes you can get glaucoma, you can get vascular abnormalities. So if you want to check how much of neurovascular damage these patients have, and also considering risk factors for cardiovascular disease, for strokes, the retinography is a good exam to assess it. I also like to do the bioimpedance, where we monitor weight, we monitor muscle distribution, lean mass, fat, and is nice when sometimes you put patients on therapies that may increase weight, and some others that decrease weight, like topiramate and melatonin. And also, obesity is a risk factor, and sometimes you have to address this issue too. All right, what is the medical team and the healthcare practitioners that you may have around you? um, you know, you can be your own headache clinic. Yes, you can be by yourself. So there are two concepts here. First is you, the headache specialist, is the center of everything. And you provide, you send patients to other healthcare practitioners. They are working together, but not in the same building, not in the same room. That is possible. I work with several other colleagues, but I like to have the best ones. And the best ones are not affordable to get around you. In the system here in Brazil is not that you hire someone in the university and they stay forever with you. First, we don't have spaces for hiring people in the university. It's very difficult. So public headache clinics are in general voluntary, are made of people that are um, trying to learn. So you put the fellows or residents or students to help running the headache center. So it is a deal where you give, they training and they do the work, like they run part of the clinic. So we'll consider this aspect of public versus private in in the next few slides. But the setting where you have everybody with you is nice, but very costly as well. So if you have the opportunity to train someone and to train the group and to have meetings together and have a long lasting, length of stay of these people in the team, then it's fine. But, if what happened in the past is that I was training like a physical therapist or even other physicians and they left. So you end up having to train people all the time, and so it's not feasible. And in the end, when they get better or when they're good, they go to their private clinics. So that's kind of frustrating. But what I like is to send my people to the best professionals. So I have 2 or 3 very good physical therapists with different skills. I have good people to send for TMJ analysis. I have people that does acupuncture and traditional medicine. I have I rarely send to nutritionists, but I do have someone that can help sometimes. And I have some nurses that sometimes go to patients at their homes to give medications to them. Sorry. So yeah, I have and psychologists and also other specialists that I like the opinion. So I started my headache center like 25 years ago, and I tried several settings. I tried to do all at once. I tried to, all sorts of models. But the best model, I think it worked for me. Maybe it doesn't work for you. You have to see what is, feasible for you. But this way of referring to other professionals is the best way, I think. The other aspect is that my center is receiving people that is not from the neighborhood, so 40% of my patients are flying to see me, So it's not feasible to get them at the clinic for like even a week or two. So they do everything and then they go back to their homes. And how is the follow-up going to be? So I prefer to, prioritize what is more important for this patient to have and to be assessed. And then if there is some dental care, or if there is some physical therapy, if there is anything, or psychology, they always can do online. So, but physical therapy is what is the most difficult. But in the end, the physical therapist can teach the other one and like give some directions of what to do with the patient. And also, there are several techniques and several skills that physical therapists may have in order to deliver to the patient. I like very much the laser therapy. We've done a study comparing laser therapy with Botox, and the results were similar. So yeah, it's something that you can have also in your clinic, but the equipment is cheap, and I think the physical therapist should have it. I don't know how common is that in your country, but I mean, it's just a matter of start using it, and the responses are quite good. So you can also have a list of procedures like peripheral nerve blocks, trigger point injections, Botox, infusion therapies, the spinopalatal ganglion blocks, some like the vagus nerve stimulation or TMS, transmagnetic stimulation. I know people that does neuromodulation and TMS or TDCS. We've done a study years ago, and the study showed the study was negative for TMS in chronic migraine. So I got a little disappointed, but I know we studied a different protocol. I don't think the field is dead. I think TMS and TDCS may be still a possible way to do it. But you have to know what you do. TMS is also good for depression, and also, if you offer acupuncture is nice. If you offer psychological therapy is also nice, but always like there is another business aspect that is important here in Brazil. If I have to hire this physical therapist, there is a lot of like 30% of his or her salary is governmental taxes. So, and then there is a liability of, the legal system is very bad in terms of like the risk of lawsuits from the worker is kind of high. So yeah, it's something to consider. I mean, if you face the same system, you may not want to go through this liability for lawsuits in terms of work. So, are you doing your headache clinic private or public? In the public sector or private? There are pros and cons in terms of funding. I mean, if you have funding from the government, great, but usually, it's not the case. But some hospitals or some special areas are interested in investing in that. Patient volume is very high. The public sector is lower, so you have quicker access. And that's the problem that I like to tell you, and you all know, if you have long waiting lists, you end up selecting patients because the most comorbid ones, the most difficult ones will stay, and you may lose space not for the easy ones, but the acute ones that you have to deal with. So if you block your agenda with chronic cases, you're not going to help your cluster headaches and bouts. You're not going to help your intracranial hypertension, losing visual field. So there are some aspects here. So you have to make some policy to get patients that are not doing well, so you have space to get them in. Procedures are more limited in the public, as access to medicines, infusion therapies. Research in the public sector may be better linked to universities, but what I do here is like, for instance, my affiliation with the university is not reasonable in terms of a salary. So we ended up doing almost a voluntary work. So the what I make as a salary with the university is like, I can't even tell. It's like so this I should say symbolic, but I should not complain, because I mean it's the best way I think I like to do. Like so I'm pretty much self-employed. So I run my headache center, my private practice, and I can like go to Jakarta and spend wonderful days with you. So I didn't have to ask to any boss. I just managed my schedule, and that was it. So and also because I'm with a role in the IHS, I have to be flexible. I mean, it would be a disaster if to any meeting or to any thing that I have to attend, I have to ask somebody to go, or to, it will be a disaster. So let's talk a little about the clinical workflow. So it is important to do some triage and like I said, identify urgent headaches. Consultation, how much time do you leave for a first consultation and a follow-up? It depends on how fast you can get, or how many people, if you are having the fellow taking the history first, or the student, and then you have a discussion. So, I mean, in average, it's 1 hour is comfortable for the first, but it depends on again, on the which setting you are. If you sometimes you don't have that hour, and you have to put patients in, and you kind of spread the time that you have with the patient in other consults. So and get the help of the psychologists or the nurses to get more history about their lifestyle, about their psychological aspects, and then you can dedicate less time if you have time constraint. You also need to manage the plan, acute, preventive, and non-pharmacological, and maybe need procedures, and of course follow-up has to be also planned. If you are seeing someone and you don't have space for the next 6 months, so it's kind of difficult if you have to manage someone with some detail in a range of many months between consults. very important to do research, I think, in headache clinics. It's, you know, of course, there is the business perspective, but what I think drives us the most is the interest in innovation and the improvement of quality of life of patients and to, you know, test our hypothesis. We are always thinking in new strategies, and we may have our own strategies for certain diseases, and we have to show what is good in terms of solutions. In terms of interaction, I can share the presentation with you, but so you can get those details. But we can interact with several specialties. Sometimes it is too difficult to access in one setting a certain specialty, but you kind of have to establish some relation with many specialties. ER is very important as well. There is a role of a headache clinic to improve headache management, and also probably the headache clinic will save money from the hospital because you're going to do less ER visits, you're going to do less MRIs, and you improve patients' life. So the headache clinic can be the acute treatment hub, and you're going to get cost reduction, increase effectiveness, and of course, data and quality improvement. So there are a lot of examples for implementations. You can start with the ER or in the hospital, or you can start with ambulatory care. It's a matter of what is the easiest way for you to start with the center. You can start by yourself and building your community, your associates, affiliates, and then you go from there. So you may have the benchmark of pain clinics, but I don't think it's totally the same shape. In conclusion, I think, of course, it's very important to set up specialized headache clinic. It requires medical expertise, procedural capability, and administrative structure. The private sector allows greater flexibility and faster growth, but needs initial investment. The public sector allows for broader access, but may face resource constraints. And both can drastically improve patient outcomes when implemented effectively. If you want to dedicate your time to headache medicine, start your headache center and keep improving it. Thank you very much.
Thank you, Professor. Thank you for your excellent and comprehensive lecture. Very nice. We did because it is very late at your place. Maybe we can take first question to you, and then you can rest because I think you're very hectic for tomorrow. Yeah. So I would ask the audience bisa bertanya dalam bahasa Indonesia if you would like, and I can translate it into English. Pertanyaan untuk Prof Mario dulu, setelah itu Prof Marionya bisa istirahat kan di sana jam 23.45 ya, dan udah itu. It's okay ya, Profesor Gianluca ya, I suppose ya. Ada yang mau bertanya? Silakan dalam bahasa Indonesia. Jadi menarik. Ya, silakan Dr. Kevin. Dr. Kevin is one of our fellow, yeah, already neurologist. Now he's doing his fellow pain management intervention. Please, sir.
Sorry, but I want to ask Prof. Gianluca. There's
Sorry Pak Ferry, pertanyaannya untuk Dokter Mario, Prof. Mario dulu.
Prof.
Soalnya dia
Prof.
udah
Mario.
1:30 malam, kasihan.
Okay, Prof. Mario, I want to ask one of your slides in order to open the headache clinic. One of the requirements is affiliated or certified by organizations like IHS. Is there any chance for us to be certified by the IHS? If so, is there any pathway for our young neurologists in Indonesia so we can open the headache clinic in our private practice? Thank you, Prof.
Well,
Okay.
good question. Is not a obligatory requirement. Is affiliation as a member is nice. You have to be part of a community, and certification we are starting to put together, and hopefully in the next year we'll have a certification up and running at the IHS, individual certification, like headache specialist certification. And the plan is maybe in 2 years or more. It's difficult to do, but also certification of headache centers as well. It is costly, but we are far advanced in the certification process, in the individual certification process. It is something that we're gonna have to work together. Like we are piloting in China and probably in South America as well. And as soon as we have the structure up and running, we're gonna have to translate probably in Indonesian the materials and establish the relationship between IHS and the local national society in order to, there are several steps, but in the end, I think is going to be very important if we be able to start this and to provide this for the international community. So hopefully in the near future, we'll be able to do it.
Thank you, Professor. Another question? Yes, please. Dr. Winu Groho, our staff in department.
Hello, Dr. Mario. I'm sorry I didn't meet you at the conference. After I hear your lecture and Dr. Professor Gianluca as well, at first I was happy that there's a neurophysiological examination that we can use for to detect migraine or to differentiate migraine with other diseases. But in your lecture, you didn't mention about a requirement of neurophysiological examination in a pain clinic. Would you recommend that as an exam tools that you use in the clinic, or is not maybe more advanced clinic to do that? Thank you very much.
Yeah, it's a good question. The problem of neurophysiological testing is that it's good for research, good for understanding the cases, but reimbursement is difficult, at least in Brazil. So how would you? I mean, you can bill biofeedback. Most insurances, I think, will probably pay. So it is something that you can add as a tool and a procedure. We do have an algometer that we bought, but for research. It is nice also to test and to show the patients EMG recordings of and so they can understand how much tense they are. But I think Gianluca can explain that better because he has more experience in the tools and and how you may use it, or even if it's cost effective. Like I know the QST uh, um, equipment is very expensive, and I don't think is very useful. And we kind of use only the pressure threshold part of it. So we use the algometer. But again, it's not in the clinical practice, it's more for research. So yeah, it's nice to include, but then is another time, who is going to measure it and how much time that will take, and what are you going to do with that data, or with that information, or is it going to be helpful for the patient? So um, I did not include as a mandatory um, equipment, but yes, certainly is something to include.
Okay. Thank you, Professor. Interesting, yeah. Dr. Winugroho, Professor Gianluca is the basic before he's coming to headache specialist is a neurophysiologist, yeah, professor, yeah, and having his first thesis using EMG as a tools in the headache. Maybe later you can explain, yeah, about it. Okay. Another question, maybe last question, perhaps. Okay, if there is not question, maybe I would like to question Professor Mario. How often do you consult with other specialists? Like you said, that there is a psychiatrist, there is a radiology, there is anything that. How often do you take your patient to take another consultation and to make a diagnosis of the patient that come to your clinic? Thank you, Professor.
Wow, and it is a very difficult question because it depends on the patient, and I must say that I have two situations, two different patients. One that is coming already from the psychiatrist or the other specialty, and they're asking for my diagnosis or second opinion. So yeah, maybe half of my patients are already being taken care of some other physician, and the other half is mainly I'm the one taking care of the patient. And in those patients, so in the other half, I would say 100%, they've been following up with other specialties. In my other half, I would say um, the question is, the more you go into specialty, the less you ask for a second opinion. So in terms of psychiatry, I don't ask too much, but in severe cases, I like to have someone, mainly because of liability, and it's nice to share responsibilities in difficult patients, particularly psychiatric patients, and some patients like um, eat disorders. You need a setup to treat eat disorders. You cannot treat by yourself. Schizophrenia is difficult. Addiction is difficult. But the regular, you know, psychopathology, I think, is up to us headache specialists to, understand and make the diagnosis and deliver at least, the very initial and middle, like, severity cases. Um, it's hard to tell what is the percentage of asking for a second or for an opinion from a psychiatrist. I send to ENT a lot. I I do, I diagnose many of the nasal disturbances, and I start with clinical and non-surgical treatments. And, maybe in the end, some 10 or 20% will need surgery. Then I send to ENTs, but I do the first basic management of chronic rhinitis by myself. Um, in terms of posture and physical therapy, I send many patients to physical therapy, more than half, I think, and also more than half for psychologists. But they don't go, they don't like. I mean, that's another thing that is important. I mean, if you send to too many physicians, too many healthcare providers, um, some people like, but we have to think about, we have to prioritize, So what is not cost effective? What is probably wasting our time and patients' time? I think we should not do. Um, so that's why I don't send too much to nutritionists. I do the basics, what the patient should, more importantly, know about and to diagnose, some pattern. But I would say, yeah, psychologists and physical therapists are the most common referrals that I send to.
Okay, thank you, Professor. Okay, I think that was the last question, Professor. We were aware that this is already night. Thank you for your joining us. Well,
Thank
can,
you.
can you give Professor Mario a clap? Thank you. So thank you, Professor. If you would like to last, thank you so much for your time and your giving lecture. We will inshallah bet in Brazil, I think, yeah, in September, yeah.
Excellent. Thanks for having me. I had wonderful days with you, and I hope to come back soon.
Okay,
Work
thank you.
together. There's so much to do.
Yes, thank you, Professor.
Thank
Okay,
you. See
bye,
you
Professor.
soon.
Okay, now for the time for Professor Gianluca. So
Bye
there was
bye,
a
Papa
question.
Gianluca.
Huh? Yeah.
Say bye to Papa Gianluca.
Okay, we will. Thank you, Professor.
So the question about electrophysiology. I must say that based on one single patient, we cannot make a diagnosis. We cannot make a diagnosis of migraine or any kind of private headache based on one single electrophysiological test. Anyway, I must say that we performed some study using multiple tests on the same patients. If you increase the number of tests, you have the possibility to two tests, increase the probability to make a correct diagnosis. So performing multiple tests like auditory and visual, and auditory and somatosensory, or the three tests, you can increase the probability to catch one single migraine patient, especially in chronic migraine. Why? Because according to the classification, it's harder to make the diagnosis of chronic migraine than episodic migraine. It's simple episodic migraine based on history taking, physical examination, and so on. It's quite easy to make a proper diagnosis of episodic migraine, but not chronic. Why? Because when you have a everyday, a daily based headache, or you lose part of the clinical symptoms that are accompanying migraine. Sometimes you have no nausea, no photophobia, but you have a headache. We have a mix of tension type plus migraine headache spreading across the days of the month. So in this case, probably being sure that you are dealing with the patients affected by chronic migraine or chronic tension type headache could be hard. So in this case, electrophysiology could help. But I have to add that in the last 10 years, there were many attempts to try to use electrophysiology as a way to prognosticate, to forecast migraine attacks. There were devices developed for this purpose. We even, made a specific microprocessor system on chip to prognosticate migraine, and it was a collaboration with Singapore, and so with engineers. So there were devices using electrodes over a specific diadema or like sunglasses. So it will be, I think, possible to say that in the near future, we will have some device able to prognosticate migraine using electrophysiology, combining skin electrodes with electrophysiology, doing real-time monitoring of patients. So it's like for patients affected by diabetes, using some device to deliver insulin, we can use devices to prognosticate migraine and deliver the triptans or GPANs, whatever. So this is for, I think, close future. I don't know if I answered the question,
Yeah.
someone posed.
Oke, Dokter Wino gimana dok? Ada? Udah.
So you mentioned that you need several tests to use like the BPs, SECP, and also the clinical effects to whether. Yeah, I understand because the habituation can be on the visual, also in the somatosensory cortex, or whether it's in the brainstem. And then, do you think it's another tools that we use here in Jakarta is the vascular migraine index? Or what do you? How about it? How about that?
There are, it's an old way to study migraine pathophysiology. Since I think the first article was from my original group in Rome, was published in 1997 about Doppler sonography and vascular reactivity. It's a way to study, this neurovascular coupling. Another way to study neurovascular coupling in a way. So it's a reactivity of the brain, but we cannot make a diagnosis of migraine based on this test. As I told you, since migraine is something that is related to brain changes, it's a cycle, premonitory, aura, headache phase, post-headache phase, intericta, variable length on the rita phase, many days, even months. In my case, I suffer from migraine without aura. And my last attack was 3 months ago. But having no attacks means not having no migraine. I have the diagnosis of migraine. Even I do not experience attacks for this very moment. Maybe when I come back to Rome, I don't know. So it means that we cannot use one specific test, Doppler sonography, visual evoked potential, to perform a diagnosis of migraine when my last attacks was 3 months ago. It's impossible. But why it's impossible? Because as I try to show you, there is such a relationship between the distance from the last and the next attack with electrophysiology, but also with the neuroimaging, metabolism, PET, functional activity, fMRI, microstructure, microstructure, whatever you want. So we cannot say I am there in the middle of an attack, or I am there during the premonitory phase, just with one test. But using multiple tests, maybe we can increase the probability to catch this specific phase. This is for the future. Okay.
Okay, thank you, Professor. Thank you, Dr. Wino.
Thank you very much.
Okay. Ada another question?
I maybe have more question, but it's a more deep question. So I will give
Because
the
okay.
other participant to ask.
Betul. Oke, thank you. Ada yang mau nanya mungkin dalam bahasa Indonesia? Ya silakan Dokter Kevin tadi, maaf ya. Heeh.
Thank you, Prof. Gianluca. I have three questions for you regarding the habituation deficits, which is a very interesting topic to be discussed on the migraines. Uh, you notice that there are two places habituation deficits. My first questions in the grandstand have the nuance that I get impressions that actually the migraines, actually, if you don't actually have the attack, then it's still, the problem is still there due to the genetic and some neural separate deficits that you already mentioned. So what factors actually causes the shifting from low frequency to high frequency episodic migraine related to the clinic based on your explanations? And actually, there are some publication, the case reports reporting that monoclonal antibodies of CGRP actually have the modulating effect of the migraines, and actually it reverses the habituation deficits in the brain stems. In your research or your expertise, is it really although the case report, we only report only 3 months, but do you think it's persistent on the modulating effect, or is it only temporary as long as the drug works? My second question is actually the habituation deficits in the thalamus, that you notice the low frequency, the episodic migraine and the medication of use have the habituation deficits, but not in the chronic migraine. Why so? And the third, actually, the SSRI in migraine, do you really support the use of the escitalopram or even the venlafaxine to reverse the habituation deficits in the migraine? That's all my questions. Thank you.
Lots of questions. Um, the first one was about habituation deficit. And the transition between episodic and chronic.
Low frequency to from low frequency to high frequency. Why if the migraineurs have all the habituation deficits, someone actually have the low frequency, but the other people have the high frequency regarding the habituation deficits?
What I can say to you that literally migraine has lack of habituation to in response to every kind of stimuli except the olfactory one, because it's not passing through the thalamus. So the thalamus is the key to this kind of phenomenon. At the base of this phenomenon, thalamocortical dysrhythmia. About the transition between low frequency to high frequency. It depends on the frequency of the attacks, because there was a relationship, a correlation between the frequency and the habituation. The more the frequency, the more pronounced is the habituation, not the habituation deficit, but the habituation, because you are approaching the attack. When you have a normalization of every kind of response, it's something like a brain reset. When you have a block of the computer, you have to reset the computer. So the attack is the reset. They establish an homeostatic condition. It's a stress response with the hypothalamus. So the more the frequency, the more the habituation, not the lack of habituation. We found the maximum lack of habituation where we are a higher distance from the last attack during the interictal phase, because we are predisposed to the next attack. So this is the correlation with the high frequency. But I must say that the increase in frequency means the increasing in the use of medication. That is your second question. We showed in the using the SSCP, so sensitive okay potential, but also TMS, and that the more drugs, acute medication you take, the more increase is the lack of habituation and the sensitization. And it depends on the type of medication you take. I mean, it's minimal with triptans, because triptans, according to Rami Basten papers, is a race against sensitization. Take when early treatment. It's not the same with the non-anti-inflammatory drugs or combination of drugs. When you prescribe or you take lots of non-anti-inflammatory drugs, you can induce sensitization, central sensitization. So you increase the amplitude of SSEPs, and you have a huge increase along the stimulus. So lack of habituation, sensitization, and persistent sensitization, lack of habituation, because of the medication. So this change between episodic, low frequency, high frequency, because of the frequency and because of the use of the medication overuse. So if you stop medication overuse, you stop sensitization before all. And then after some months, you stop lack of habituation. And you can restore a normal habituation. But this phenomenon, the third question, is transient. It depends on the duration of the medication effects, the preventive medication. Like for monoclonal antibodies and for topiramate, for valproic acid, well, with venlafaxine as well, using VAPs in the past, was a Turkish group. And about the other question about SSRI, there is one paper showing that venlafaxine could revert a normal habituation in patients lacking habituation up to 3 months. 3 months. But again, this is transient, not persistent, because there is no drugs being able to change your brain. You know, it's not disease modifying. There is no drugs in migraine that are able to change the disease, like in MS, multiple sclerosis. No, I must say. So it's in the genes, it's in the brain changes according to the phase of our in life, like the menstruation in women, the menopause in women. They may change particular reactivity and habituation level, but it's not depending on medication. But for sure, medication overuse and the type of medication we are overusing is increasingly important in changing your brain activity and inducing not only migraine chronification, but also central sensitization, and increase the probability not to revert to a normal condition. So one of the behavior or the non-therapeutic procedure to treat migraine is to stop overusing medication. Acute medication.
Okay, thank you. Sorry, karena waktunya sudah habis, kita sudah diingatkan dari ruangan, because the time is already up for the use of this room. So I think we can conclude it for this guest lecture. Mungkin sekarang pemberian sertifikat ya. Ya. Dr. Winugroho, boleh dok sembari turun untuk perwakilan KPS. Sembari mungkin juga menampilkan video salah satu sama 1 menit ya, salah satu sponsor yang juga sudah memberikan apa namanya jalannya acara ini untuk petunjangnya ya. Jangan lupa we do have a headache diary now, you can use it ya. Artinya suaranya banyak yang mengira kami hanya memproduksi produk otomatis. Faktanya kan, kami juga memproduksi produk konsumen, produk nutrisi, dan kosmetik. Ekuitas merek kami telah menjadi market leader. Temposcan juga memiliki 8 fasilitas produksi yang tersebar berbagai wilayah Indonesia. Hampir semua produk kami diproduksi di dalam negeri. Jaringan distribusi kami mampu menjangkau seluruh wilayah kepulauan Indonesia dan Malaysia. Bahkan Afrika menghadirkan produk-produk berkualitas dengan harga terjangkau. Selama 70 tahun membangun integrated business ecosystem berkat kerja keras dan dedikasi 12.000 karyawan Temposcan. Tidak berhenti di sini, Temposcan terus mengembangkan bisnisnya dengan inovasi tanpa batas. 70 tahun Temposcan, building the next frontier. Oke, thank you. Thank you, Profesor Gianluca. Tampaknya kita sudah sampai ke dalam acara terakhir sesuai dengan waktunya dari jam 9 sampai jam 11. Nanti serangkaian guest lecture ini juga bagian dari Jak News. Nanti kita akan coba bagaimana menjajaki kerjasama antara Indonesia juga dengan IHS kemarin juga sudah ada rapat dan kita sampai ketemu pada Jak News tahun depan. Terima kasih atas kehadirannya. Kita boleh foto ke depan, Profesor Gianluca, because we Asian people like to be photoed. We would like a photo with all of the participants that come to here. Terima kasih.
Selamat siang dokter semua, mungkin boleh untuk buat maju ke depan untuk kita sesi foto bersama. Untuk backgroundnya di sini, nanti kameranya dari sana. Oke, baik, mungkin bisa dibantu untuk dipercepat untuk buat foto bersamanya dokter-dokter semua. Izin dok. Oke, oke. Boleh merapat lagi dokter-dokter semua, izin. Oke. Oke, kita mulai ya dalam hitungan ketiga. 3, 2, 1, cheese. Lagi. 3, 2, 1, cheese. Oke, once again. 1, 2, 3. Oke, thank you very much. Terima kasih dokter semua.
Jadi buat dokter-dokter juga mungkin bisa isi kuesioner, ada QR code, boleh tolong difoto ya untuk dibantu isi terkait bagaimana begini.
Oke, izinkan ini di depan ada scan QR code untuk buat kuesioner. Jadi kami membuat satu kuesioner, mungkin boleh untuk dokter yang belum scan untuk buat di scan ulang ya dok. Kalau mungkin tadi belum bisa scan ya. Terima kasih dok.
Ya, dokter-dokter boleh di-scan lagi ya kalau tadi error karena udah bisa dibuka lagi, boleh langsung di-scan aja. Terima kasih.